And then do you guys get the pop-up that says, yeah, you're being, you're being recorded? Excuse me. Okay, so I will repeat for the recording that there will be focus areas posted for the NRN 56 quiz that's this weekend that opens tonight, or opened tonight at 5. So when this meeting's over, I think like I have it set to go up at 8 o'clock. So you'll have focus areas for the quiz. And then for the quiz for NRN 58, I will extend the date. It is still live as of now, but I'll extend the date to like Wednesday at midnight. So any students that were wanting to take it at the regularly scheduled time have that available. I just would caution you to keep the information to yourself because it is open longer. The quiz results should be open for 56. I don't believe they're hidden right now for the quiz. So you should be able at least to see your score. I don't know, you can contact me. I hesitate to open up rationales because then people might, can copy questions or can do things. So I'm hesitant to just open up rationales. But people can contact me if they want to go over their quiz before the exam on Monday. But again, you'll also have focus areas for that as well. Okay, any questions before I get started? And this is going to be pretty, not brief, but like pretty basic. And again, I'm just going over my questions. So let me find my objectives. Okay, so for, we'll start out with grief and self-care. And so there are 5 questions for that area. And those are going to focus on developmental responses to grief. So I have on the objectives, I have that list of how different ages respond to grief. So you would be responsible for that information. And then the other objectives are the emotional response of parents. So emotional responses to the loss of a child and emotional responses of parents to a child with a defect. And know that that also talks about therapeutic communication, things that the nurse can say that are therapeutic in those situations. And then also ways of allowing expression of feelings for parents. And also self-care for nurses. So if you recall in the lecture or on the lesson page, there's an article about 8 areas for self-care. So I would go through those categories and there'll be a question related to one of those categories. Does that make sense? Question,
I have a
Danielle?
question.
Mm-hmm.
You said therapeutic communication, and then what did you say after that?
Excuse me, in terms of therapeutic communication, in terms of emotional responses of parents. So there's, we're assessing what the parent looks like, right? And what their emotional response is. And then we have an intervention, which is generally therapeutic communication.
Okay.
It could be a thing as well, an intervention, but it could also be communication. And then also that follows along with allowing expression of feelings of the parents.
Okay.
And if you look at the objectives, those are separate objectives.
Okay. And then the one after that, you said like ways something. I was writing it down and
I don't know, somebody help her because I don't remember.
Okay, I have it. So ways of allowing expression and feelings of the parents. That's pretty much it.
Okay, thank you.
And then I think I said the self-care, right? Those areas for self-care.
Yep.
Okay, hold on, sorry. Let me go back to, I don't think I have these in the order by week, sorry. For the gas exchange component, there are 6 questions. There are 2 questions for COPD. There are 2 questions for pneumonia, and there are 2 questions for cystic fibrosis. The questions for cystic fibrosis center on nursing interventions. And if you look at those objectives, the number 4 objective is to provide appropriate nursing and collaborative interventions to optimize gas exchange. So that's where those interventions fall under. There's that like pick list: smoking cessation, pharmacological therapy, inhalers, O2, mucus. There's that list. I don't know if anybody has the objectives up, but that's what that falls under. So there's different nursing interventions for clients with cystic fibrosis. And then for COPD, chronic obstructive pulmonary disease, looking in terms of what nurses should be assessing for, and what to do about secretions, like being able to assess that, and then nursing interventions. Also kind of like along the lines of client education, what you might tell the client to do. And then pneumonia, we had mentioned what hospital acquired, ventilator acquired. We also had mentioned aspiration pneumonia. And so of those that we talked about, I would focus on aspiration pneumonia. And then also risk factors for pneumonia. So remember we talked about pneumonia as a complication of cystic fibrosis and COPD. And so what are risk factors? What risk factors, what things put people at risk for developing pneumonia? Just let me check one thing, sorry. I think I have the same question on the quiz that I have on the exam. That's not gonna be good.
That's
Oh yeah, that's okay. Sounds
No,
perfect.
just leave it. Give us a trial run. We may get it wrong in the quiz.
That means we will really know that answer, and we will understand the question well.
Oh, got it. So you want me to make it a mastery question?
Mastery question.
Is that what you're saying? I
Yeah.
should make it a mastery question? Oh, all right. Not the same question, but the same concept. So that's okay. Just asking the question in a different way. So you do have to know heart failure. So remember, like today, the first thing that y'all went over was heart failure. And so you would need to know things, discharge teaching, things that you might teach the client in how to manage their disease when they go home. What are some of those things that you can think of?
Like diet.
Yeah, that's one.
Positions of sleeping.
Okay.
Like rest.
Rest. What was another one?
Daily weights.
Daily weights.
Recognizing when the condition's getting worse.
Right. So like when to call the doctor.
Medication education.
Yes, medication education. And there's still one more that I haven't heard yet.
Encourage exercise.
There we go. So of those list of things, those are things those things may be included in discharge teaching, the list that you just gave me.
Miss Sullinger, just to be clear,
Yes.
we're on perfusion now, right?
We are on perfusion, I'm sorry. Yes, we are on perfusion. So sorry.
5 questions.
6.
Okay.
I'm sorry, 6, I'm so sorry. Perfusion, 6 questions. And there are 3 on heart failure and 3 on congenital heart disease.
Thank you.
And so we did discharge teaching. You need to be able to recognize lab work that might tell you that a client is in heart failure. And also not just like, what's the main lab that would tell you a client has heart failure?
BNP.
The BNP. But there may also be lab values that you're worried about when there is an increased BNP. So you want to make sure that you're focusing on all kinds of things, not just one number. Does that make sense? Right? Because we're looking at the whole picture of the person. Right? So when you're looking at labs, you may be like, oh, heart failure, BNP, but there may be other things going on. Does that make sense? Like there may be other things, there may be other information clues that the labs are giving us. And so that's what you want to always look at, the whole picture of the client. What medication might we, hold on, let me get through this question and I'll go back. What medications did we focus on, or medication did we focus on regarding heart failure today?
The Jackson.
So I would know that forwards and backwards. Was there a question on the labs? No?
I had a question,
Okay, yeah.
or whoever had a question first, go ahead.
I
You go.
had a question. What did you mean, like a outside of cardiac, like a BUN or creatinine, or was this something like, am I going in
mean,
the right direction?
Yes, you're going in the right direction.
Thank you.
That's not the only direction, but that is one of the right directions. Danielle, did you have a question?
I guess it's more specific and you probably won't answer that. It's kind of like knowing the lab values of, like the numerical values of the BNP, but that was it, I guess.
Yeah, I mean, to be able to recognize what lab values would indicate heart failure.
Okay, thank you.
And so BNP is one of them, and like Mirta had her suggestion, and that's all I'm gonna say about that. And then the other 3 questions are on the congenital heart defects. And so basically you need to be able to recognize the ones that I talked about today in class, which is a shorter list than what's in the PowerPoint, right? So to focus, hold on, being able to recognize that there's a problem, to know, you know how we talked about if it's a right going to left or left going to right, whether that would increase or decrease the pulmonary blood flow, which has to do with cyanosis and being acyanotic. So to understand the flow of things, the flow of the blood. Okay, and then so let's see. So then neonatal abstinence syndrome. It has 5 questions. And so again, being able to identify that an infant is experiencing neonatal abstinence syndrome. You would also need to be able to identify or notice characteristics for fetal alcohol syndrome. which we talked a little bit about in class, but it's also in your newborn assessment. And then,
I have a question. Sorry.
So it's okay.
I remember reading on like that PowerPoint about fetal alcohol syndrome. It was like characteristics include like the thin upper lip. Oh my God, what's the other one? Can you kind of go over that really quickly or?
Nope.
Nope. Okay,
Nope.
thanks.
You could go in that direction. Let's see, and then and you don't have to know the Finnegan, but the Finnegan really gives you, and the care map that you did, right, really gave you, I think, a good picture of what this type of infant would look like. So there may be questions that that relate to noticing, to assessing that this is what the child has. And then discharge teaching. What would we want to do? So say the mother is going to take the infant home. They're still experiencing some symptoms of neonatal abstinence syndrome. Are there any specific, or not specific, but like what things would we want to tell mom in terms of discharge teaching for safety for the infant?
Like medication education.
So maybe
if they're
medication.
going home on meds. Definitely like sleeping position. I'm thinking of like the stimulation, like less stimulation, less lights maybe. But I know that that's more in the hospital. Well,
but we can still, if the Finnegan scores are lower, right? If they're, 1s and 2s or 2s and 3s, maybe even depending, the baby can still go home, right? They may not go to foster care, and so you're on the right track there. What other things were you thinking about in terms of infant safety?
Maybe the pacifier.
Pardon?
Like pacifier.
Yeah. To let them know that that's okay.
Swaddle the baby. Everything that nurse does in the hospital, basically, we would advise the mom to continue to do so, and maybe teach them like if there's anything severe that's coming up, then they have to take the baby back to the hospital. That's my only way of thinking, but I don't know what else.
Yeah.
Also educate on.
Sorry, I was just saying like signs and symptoms to look out for, and like, of course, always, but like don't leave the baby alone, and to keep an eye out for some of these symptoms and when to know to call for help.
Right.
Also educate on like if the mom's gonna breastfeed or whether it's formula feed, depending on her choices. I mean, of course, you would want her to get sober, but if that's not the case, educating on the risks that can bring as well.
And nutritional information, like how when we talked about feeding the infant, what kind of pattern did we talk about? Like how often?
Yeah,
wasn't it like every 30 minutes or something?
No, we don't want it to go. We don't want a feeding to go longer than 30 minutes because that uses up energy.
Every 2 hours?
Yeah, like frequent small feedings, right? And so, I mean, you might think, oh well, what if they have diarrhea? They still need to eat because they're using up energy. They need the calories, right? So small frequent feedings. Yeah, you guys are on the right track. You're good. And then we talked about, let's see, so alterations in nutrition, the cleft lip and palate, that whole lecture. So I'll give you like the specific ones to know. We went over most of them in class, but not all of them. So that's why I wanted to give you a heads up. So we talked about cleft lip and palate. So there will be, I'm sorry, there's 8 questions in that category. And so cleft lip and palate related either to feeding or pre or post-op things that have to be done for cleft lip and cleft palate. I believe there's slides on that in the PowerPoint. And so what are you probably mostly post-op, but what kind of things post-op are you worried about for a child with a cleft lip repair or cleft palate repair?
The safety devices to keep the child from touching the wound, the scar, or healing.
Like what? Like what?
No-nos.
Yeah, no,
The
no, like
Logan
photos.
Not no does, no no's. Yeah, right. Yeah. And the Logan's bow, they call it the Logan's bow that comes around, the no-nos, those kind of things. So like safety things, right? What are some things after cleft palate repair?
Oral care.
Yeah, oral care, gentle oral care. What else?
No sucking.
Right, no sucking. And so, there's like a bug like flying around, it's driving me nuts. No sucking. So what does that mean that they can't have?
No
No
straws.
pacifiers, bottles.
Yep, all the above. There you go. And then pyloric stenosis, we didn't really talk a lot about that, but the stenosis is a narrowing. And so when the it's not necessarily apparent as a newborn, but the infant will have projectile vomiting. And so projectile meaning like across the room, like not just bleh, all over themselves, but like bleh, out. Because of the stenosis, the regurgitation comes up and pushes the emesis out. Does that make sense?
I'm sorry, can you say that again? It was
I can.
pyloric.
Pyloric
Pyloric,
Yeah.
thank you.
stenosis. It's in the PowerPoint and I believe also in the reading. And it's something that happens. I mean, you can be born with it, but you also may not see manifestations for a week or 2, or maybe longer, depending. And one of the other things is if you think of the narrowing, you can actually feel it. They'll say it feels kind of like a like an olive, like a little olive. You know, I don't like olives, but y'all know what an olive is, right? So if you were doing palpation, you could actually feel the stenosis. You could feel where it narrows and it kind of feels like a little nodule. So that's another assessment piece for understanding or noticing if a child has pyloric stenosis. If the child has, there's Ms. Clark. If the child has emesis, what are other things that we're worried about?
Dehydration.
Yes, yes, and yes. Hello, Ms. Clark. Right, so it's not necessarily about just that particular disease process exemplar, right? There's other concepts, things that happen about that. And then also looking at, they would do surgery. And so looking at what post-op care might look like for that child as well. We didn't really go over phenylketonuria or galactosemia. So I would double check or read up on those and look at those. The one key point for galactosemia is that it is one of the few times when actually a mother cannot breastfeed because of the where's Maria Rodriguez when I need her?
I'm here.
So galactosemia.
Yeah.
Do you remember galactosemia?
Yes, I do.
So galactosemia is it's a blood test given to newborns to check for a rare genetic disorder. And then it prevents the body from breaking down simple sugars, the galactose. So galactose is found in all dairy products, so breast milk and baby formula. And that's why you can't.
Thank you, Maria. It's okay. I asked Maria. It's okay, Lex. That was good. Alexis, that was very good.
Thank
So
you.
you're welcome. So that is one of the reasons why you can't breastfeed. So then there are specific formulas that don't have that substance in them, and so then you basically have that. So it's pretty difficult to. It's obviously you can live with it, but it's like worse than being like gluten free, having celiac, things like that. Like it's just really, ugh. Glad I don't
Mrs.
have
Sully,
that.
you said galactosemia, and what was the other one?
PKU, the phenylketonuria. So
Okay.
remember we do the newborn screen, and so that can check for we used to call the newborn metabolic screen the PKU because it originally was used to test for phenylketonuria. But then because it ended up testing for so many other things, now it's really known as the newborn metabolic screen. But a lot of us older nurses still call it the PKU just because that's what we know it as. So what you need to know is how you would assess for it and complications. And
Will you
yes.
Will you call it PKU? Because that's what you're calling it now. You won't say it's, what did you
Well,
just?
so the test that you do for it is the newborn metabolic screen,
I see.
which we used to call PKU. The disorder itself is called phenylketonuria, which is abbreviated as PKU.
Oh, I got it. Okay.
But I would probably put both. I'd probably put phenylketonuria and then put PKU in parentheses.
Okay.
Okay. Because these are all things that have to do with nutrition and actually alterations in nutrition.
Miss Sullinger.
Mm-hmm.
So with PKU and you're saying complication, are you saying like maybe the restrictions of food that they might have? That's okay, thank you.
And then we will in a couple weeks get to like celiac and some of those other diseases when we talk about adults as well. And then the so the tracheoesophageal fistula, you won't need to know specifically like this is atresia or fistula or all those different kinds, but you would need to know how you would assess, like what are some things that the infant would do that would make you question whether they might have a tracheoesophageal fistula.
It's like when placing the NG tube.
Mm-hmm. Yeah, that's one of them. Yep.
Regurgitating food.
Yep. Mm-hmm. And that could be, that could be other things, but it might be that. So
yeah,
that's what, yeah. And then the last one is on, and that's only 7 topics. This will only be 7 topics. So something has, a couple questions on it, but we talked very briefly about gastroschisis and omphalocele. And there are 2 slides or articles at the bottom of the lesson that talk about it. It's important because one of the big complications from these 2 disease processes is necrotizing enterocolitis. So remember, we've talked about necrotizing the NEC, the neck, a lot. And so with gastroschisis, it's where the intestines are outside the body. They're kind of next to the belly button, the umbilical cord. And there's not usually other developmental or comorbidities with it. There can be, but not usually. Omphalocele is where the intestines are born outside, but there's a membrane around them. So they're encased in the membrane. And that one also has some comorbidities, some other chronic conditions, usually some heart defects. We've been talking about heart failure. There's breathing issues. Also some genetic, can be some genetic problems with that. The children that have omphalocele have a shorter lifespan, whereas those with gastroschisis have a pretty normal lifespan. If the omphalocele is just that piece of the intestines and they can do surgeries, then that outcome is good. But if they have all those other comorbidities, then it's not. But when they're born, the intestines are outside the body. What are we supposed to do about that?
Wrap it in a bag and put it in saline.
Because why?
So they don't dry out and
Because
we prevent the necrosis.
Yeah, what's another word for the necrosis that we're trying to prevent?
Dead cells, I don't know.
Well, yeah, I mean, and if they're necrosing, they're going to be, starts with an I.
Infection.
Yep.
Okay.
Ischemic.
And they're also inflamed. Ischemic, yes, because that they're necrotic, they're dead, they're ischemic, but they can also be, they're also inflamed. There's inflammation and there's infection. See how these concepts just keep coming back around.
That was last semester.
I know, but it's coming up in a couple weeks. And we are really starting to pull now from the concepts from first semester and bringing them into second semester. And so that's where we're kicking it up a notch. You have one pediatric calculation question, and it will be on a reconstitution. And there is one short answer, which will go at the end, and I'm not going to tell you because you'll be able to do it without any problem. And then the and then I have like an NCLEX little case study thing that I have, and that will that will be on cystic fibrosis. And so we look at those next gen, it's the next gen type of question. So there'll be some noticing and interpreting and priority, you know, like the case studies that you've been doing. And it will be on, like I said, on cystic fibrosis.
How many points is that next gen?
Don't know. I think each piece is 2 points. So there's, I have 1, 2, there's 4 questions, so 8 points total.
Thank you.
And those questions will go, Ms. Clark and I haven't talked yet. I don't know if we want to decide now, but her NCLEX will come at the end of her section, and my NCLEX will come at the end of my section. I just don't know which section's going first. Right now it's her section. So you're going to have to watch your time. There's plenty of time. You're just gonna have to watch your time. Okay, and so I will, like I said, I will post the objectives for the quiz, and then based on our what we just had here for the Sully session, I'll post those specific objectives that I gave you, so you'll have those as well. How's that sound?
Great.
Thank you.
You're
Thank you.
You're
Thank
welcome. Oh, there's Miss Clark. Are you ready, Miss Clark? For your portion?
I'm ready.
Woohoo.
Watching my team play in March Madness, so
Oh.
I'm game tonight. If you're into it, I know you're all studying, but go
Who's playing?
Guns.
Who do you want?
What was
What's
that?
your team? What's your team? Who's the team you like?
Team is already out. Team is
Oh.
out. It's Duke Devils.
Oh.
Find an alternate. Dog is playing, so I might go. Oh gosh, what's happening? But I'm in it now. I'm here. I'm
There you
here.
go.
I'm here.
Okay.
Yes.
So
My small little section. My small little section.
I just
okay.
made you the host.
You did. Okay. It will stay recording. Yes.
It should, yeah. And then it's currently set up for students to come into the waiting room. So you just hit admit. You should get a little pop-up and then you just hit admit.
Sounds good. No one else is coming. I can tell you. I feel like this is standing room only right here.
Okay, I'll hang out. I'm just gonna
I'll get
close my
started. So
video.
okay. So there's really only 4 topics that that's in my subject matter. So it's eclampsia, preeclampsia, and eclampsia. It's postpartum hemorrhage, preterm labor, and postpartum infection. So basically, the objective says to recognize when an individual has the problem, risk factors, causes, clinical manifestations for the following complication. So that's kind of what you're gonna see. So oh, there is somebody coming in. All right, Lucia. So for postpartum hemorrhage, we're really taking it back to, well, what is it? Classify it for a vaginal delivery. How do you classify it for a C-section? What's that number of volume? How do you collect, like, how do you get QBL? How do we collect it? How do we know? Risk factors for hemorrhage, risk factors for the hemorrhage, preeclampsia, infection and preterm labor are things that you want to look at. So there's slides on that. We've talked about that in class. I'm trying to think, prioritizing questions are there. So you will see things like, what would you do first? What is the most appropriate intervention that you would do? I'm looking at, let me see. For preterm labor, again, how do you recognize it? How do you manage it? What are the interventions we do with someone in preterm labor? And preterm labor is also premature rupture of membrane. So that's kind of interchangeable. So preterm labor, which means dilating early or going into labor early. So if your bag of water ruptures early, we consider that preterm labor as well. And then there's a next gen question on one of those topics, whether it be preterm labor, preeclampsia, postpartum hemorrhage, or infection. I don't know what other stuff you would like to know. I have a next gen question each section. I think it's a 6-part question. Is it 6 parts? And I think each part is 2 points. Let me double check. Yeah. Each part is 2 points. There will be monitoring. There will be, in a case study, next gen, there'll be a strip to look at. There'll be lots of information that you're going to get that you're going to have to slow your mind and funnel through. And like when we do the case studies in class, recognize the important information. What is the question asking you? And take your time. But Bejda, I like the way it's set up now, where you have my question, you get through my next gen question, and then you go into some more multiple choice questions. And then you end with Miss Sullinger. And so it spreads it out. So it kind of doesn't overwhelm you guys all in one spot with the new content. So I'm advocating for it to stay the same because I think it's better to manage your time. And I don't know what other questions specifically you have. There was only like 4 things that are the topics. So what I have to say about that question. Yeah, Ashley, go ahead.
So way back when we had your last lecture, I just recently reviewed your PowerPoint and I see that chart again about the different types of abortion. So do we need to know that?
One of the things we're talking about: preterm labor, postpartum preeclampsia, eclampsia, and postpartum infection. That's it.
Okay.
That's the only thing that can be on your exam, because that's the only thing in the objectives.
Okay, thank you.
Mm-hmm.
It may be on the final, but it's not on this exam.
I have a question.
Okay.
So you said the next gen is 6-part. There's 6 parts to that, but then you said like something like there's going to be a next gen for each of the topics.
No, I said it could be on any of my topics.
Oh, okay.
Sullinger said there's going to be like a next gen, and she gave you the theme of that. I will not.
Come on, pretty please.
Well, so Ms. Clark's topics tend to go together more than mine. Mine are all over the place. So that's why I decided to give you a direction for mine. The OB stuff, it all goes together.
Yeah, it's kind of like high risk OB is the lecture that we're covering. And so any high risk OB topic could be something that you're trying to, so the next gen question is going to ask you to figure out what's happening. So I can't tell you what it is, or it gives away the question. So you've got to figure it out based on what we've learned on the 4 topics that we have, what could be going on. Yeah, and it's gonna pull, the content is specific for what we're talking about, but it gives you information that we've had, like that it's building on your knowledge. Like Miss Sullinger was saying, we build on first semester. And so our expectation is, I'm gonna look at it, make sure I'm not freaking you out. There's information that will be from the semester that you have to interpret, like labs, how to read a chart, all that stuff is your knowledge that you gain. So my expectation is how to look at a strip and read it, how to look at a chart and know what the information means, that because you learned it already. And so although I'm not testing you on it, the knowledge has to be there for you to answer the question. So if you struggle in the first exam with any of that, like how do I look at a chart? What is those? Don't know the strip. Or then you're going to have trouble with those questions because it's saying, here's a bunch of information. Tell me what's going on. Kind of like when you guys get a chart at the hospital. You're reading the chart, you're looking at all the information. What do you see that's abnormal? When we talk about it a lot when we do the case studies in class is start highlighting what's abnormal. You get a paper when you take your exam, read that case study, whichever one it is, and start writing down what stands out to you as important information. What's your priority? What's going on with this patient? And then look at the question and what it's asking you, and then look at the options, because they're not fill in the blank. They're all, none of mine are fill in the blank. You're not going to fill in the blank anything. It's going to have the answers for you. So you're going to have options. You might have select all that apply, which are your favorite, or you might just have one option. So you just want to read through all of them and see, does it apply? Check it. If it doesn't, move on. And try not to get lost. If you don't know it, you don't know it. I think that's one of the things that you have to kind of let your mind go. If you just I can't remember that, then do your best and move on. Don't get stuck in the mud and, let the time tick away. Be very conscious of that. And there's just the 4 topics. So if you have questions about preeclampsia, eclampsia, hemorrhage, infection, and preterm labor, I'm here to answer any of those as well. But yeah.
Ms. Clark, so when you're telling us to know about how to recognize and manage and do interventions for preterm labor or for any of the topics, is it important to know the labs?
Yeah, you asked me one, Lex, in class.
Yes, I definitely did. So yeah,
you probably should know what that is and what that means. You can share it if you want with the group.
Okay, yeah. So definitely you guys know fetal fibronectin. It is a test or a lab that pretty much determines if you're going to go into preterm birth possibly in the next 2 weeks. Is what you told me, Ms. Clark. Yeah.
Mm-hmm. And so if you know what that means and what does the results mean, how does it impact that patient? Also, how do you manage preterm labor? What are the things that we give? What are the things that we do?
Terbutaline.
Yeah, we can give terbutaline and that can stop contractions. What else do we do? You guys my group is taking care of preterm labors. What do we do for them? Let's see. No one's here from my group. Oh wait, no, I don't think Pam is taking care of anyone. Looking, what do we give when they're in preterm labor? What are the things we're worried about? What are we worried about if their bag of water ruptures early? What's our big concern? Any specific questions? Yeah. Wonderful. Glad you guys are so clear.
Oh, choreo.
Yeah.
Maria said choreo.
With the pre-prom, absolutely. So what interventions do you do if you think that they're at risk for infection? What do you think you're doing as a nurse? What are the things that you check to make sure they're not having an infection? Anyone? Check the temp often. Thanks for coming in with the answer. Yeah. So those are the questions I'm building, like, what do you see? What's important? What's the patient most at risk for? And what are your nursing interventions? And what are your expected medical treatments that you're going to be facilitating? Antibiotic, probably prophylactically, yes. Anything else that you would want to give somebody that's pre-prom or preterm labor, medication wise? Anyone?
We can give betamethasone for
And what's that for, Katarina?
development of the lungs of the baby. So
We also can give one other medication. Do you know what it is? For the baby? Magnesium sulfate. Maria is just coming in with the charmer question. Yes. So magnesium, we have two ways we use it, right? When preeclampsia, we use it to stop a seizure. Preterm labor, it's for neuroprotection. So it's only for a specific time. It's only 24 hours and then we turn it off. But if they're preterm labor and preeclampsia, we might just keep it on the whole time because it's double duty. It's neuroprotection for the first 24, seizure protection moving into it. So you should know that the same medication has two different functions. And so if somebody is on MAG, the questions you're asking is, well, is she preterm labor? Is she got preeclampsia? What is it? And why is the doctor deciding to give this medication? So yeah, great conversation, everybody.
Can I ask
Smart.
can I ask you a question, Ms. Clark? Because we had a client, yes, because we had a client in clinical this week who had preeclampsia and then had the baby. It was a 28-weeker, and they kept her on the magnesium for the 24 hours, I believe, after the baby's born, right? They do that. And then they took away her seizure precautions and put her on 30 milligrams of Procardia BID.
Oh, for her blood pressure.
For her blood pressure. And then is Neil here? Where's Neil? Neil's here. This is your patient. And then and then her blood pressure started like spiking. And so the nurses are calling and the doctor just said, oh, we checked the blood pressure in 15 minutes. Like the nurses wanted like IV labetalol or like something to drop the blood pressure. But I was also trying to explain that just because we used to think that when you had the baby, the gestational diabetes, the preeclampsia like disappeared, and they don't. They can still be there.
They saw a video that will break their hearts, that they know that they know it does not end with the baby. That's why I show it, because I need it cemented into their brain, because they're still sick and they still can be in trouble. And it was thank you. Yeah, it's not cure, it doesn't cure it. So it's patient safety movement, where they sent her home thinking she was out of the woods, dying. So mentally remember that. And so it's true, because I think it's important to know that they're still sick. And so at SDMH, we have a protocol. And so it doesn't matter if they're in labor, it doesn't matter if they're postpartum, they spike a blood pressure, we check it again. If it's still high, we go into pre-eclampsia mode, and we're pushing meds. So it's just our standard. What I've learned this recently this week is that, different hospitals, and it's good to know, have different policies, procedures, and protocol. And so you're, as a nurse, you need to know them and also advocate for them, because is that person being well managed, just kind of throwing Procardia when it's not working at her? Probably not. And so evidence-based says you manage them on a protocol to get it to be normalized after birth, or they're heading into a seizure. It's just going to happen. So hopefully they got on board at some point. Sometimes they get readmitted, so they go home and they have to go in the office, like they say check in like 3 to 4 days, and they have high blood pressure. They'll readmit them. And the hard part about that is the babies can't come, because they can't go to the NICU because there's nowhere to put the baby in there, and we have a visiting rule and all that other stuff right now. So that's the only bummer about separating the mom and the baby if she has to get readmitted.
Yeah, this mom hadn't gone home yet. But I said, well, you know, we still have the bumpers up, you know, the seizure precautions. And the nurse looked at me and she's like, yeah, no, good idea. And went to go get them because they had taken her off after the 20, when they took her off the mag, they took her off the seizure precautions. And I'm like, hello.
Still something people are getting used to. It definitely was the old mindset of you deliver and you are safe. And so just to reframe that now is you're not until usually 6 to 8 weeks later. And so it's just something to know, you know. And so hopefully that video was a mental memory for you to cement your learning on that concept.
Nice. Well, thank you. I just wanted to throw that out there because that was a big deal we had this week.
It is a big deal, for sure, for sure. People are leaving by the dozen. They're done.
All right, I'm gonna stop the recording at some point here. Oh no, you have to stop the recording, I think.
Okay,
'Cause you're the host.
so I'll stop the recording.